Hey everybody, welcome back to the ECG of the day. My name is Reed, and don't forget to download the PDF of this document down in the description below so you can follow along, and feel free to like this video and subscribe to the channel if you enjoy the content. So let's jump into it. This is a great example of a pretty obvious diagnosis that maybe we should just try to do our full approach and not miss anything. It doesn't mean that there's anything to miss, but we need to do our due diligence, right? And the patient, we owe that to the patient. So first thing we're going to do is we're going to not look at the kind of the obvious, and we're going to do our normal thing. So say this patient comes in, right? We'll just give you a little scenario. It's a patient that's maybe 70 years old with chest pain, right? They're feeling something. So first thing we're going to do is we're going to look at the forest. And so I might look here V5, and I say I've got a narrow complex rhythm that is marching along. It seems to be maybe a little fast, but not too fast, and you can see that it stays very regular the whole way, so that's reassuring. You can see my rate here. If I find a QRS that lands on a solid line, maybe this one. My rate is 300, 150, 100, 75, so somewhere between 75 and 100, but closer to 100, we'll call it 90 beats per minute. Okay, normal rate. And it's a narrow complex rhythm. So I see that in front of my QRS complexes that there seem to be some little atrial P waves. Yeah. So let's evaluate, well, what is the atria doing? It's a narrow complex rhythm, and so I think that we've probably got some atrial activity driving this rhythm, and those P waves are upright in lead 1, and they are also upright in AVF, and so that tells me that these P waves are sinus P waves. So it's reassuring. We know that sinus P waves come from the AV node in the high right atria, and they depolarize, and then the AV node takes that signal and says, I'm going to delay it by 120 to 200 milliseconds so that the ventricles can fill with blood and so we can get a good squeeze. And so my PR interval tells me how my AV node is doing. If I measure a PR interval, what I'll notice here is I'll do it up here maybe in V1. Beginning of my P wave, beginning of my QRS, my PR interval here is maybe 6 small boxes, which is 240 milliseconds, which is a little bit long, right? Usually we want to see my PR interval to be 120 to 200 milliseconds, and so we don't see that. But we do notice that if we scan through that the PR interval is fixed at 240 milliseconds, and every P wave has a QRS complex, and so this tells me that the AV node is just a little bit slower than usual, and so this is a first degree AV block, right? Every P wave has a QRS, but it just takes a little bit longer to get there. So that's what we get. Next thing we're going to do is we're going to now evaluate our QRS complex. And so we said my QRS was narrow, right? You can see if I come up here to AVR, here's a nice picture of my narrow QRS. Like my QRS is less than 3 small boxes, or less than 120 milliseconds. The axis of my QRS is upright in lead 1. Whoa, let me write that again. Upright in lead 1, and it is upright in AVF. And so tells me that my QRS axis is going down and to the left, which is normal. And you can see I've got some R waves that seem to progress to get larger as I go through my precordium, so that's good. Last thing we're going to do is we're going to measure our QT intervals, right? And so I find a lead that's got some nice T waves, and maybe we'll say here lead V1, and so I draw lines through my QRSs, and I look to see if my T wave ends by the midway point, which it seems like it just about does. And so now we look for our ischemic changes, right? Because our patient has chest pain, so we don't want to send them home if there's something scary on the strip. And so, we look for pathological Q waves, which tell me has there been a previous or an old myocardial infarction. And we also look for active ST segment elevation or depression, or any T wave abnormalities that might suggest active ischemia infarction. So the first thing I think we all noticed is we looked at these inferior leads, and we had a little bit of maybe we skipped a beat after seeing those, right? and you look closely, you don't even need to look closely, but here's our baseline. And look at this significant ST segment elevation in these inferior leads. Baseline, ST segment. Baseline, ST segment. So there is significant inferior ST elevation, right? Those are up arrows for elevation. And so, because those are our 2, 3, and AVF for my inferior leads, that it immediately makes me think I need to look for reciprocal depression in the opposite leads, which are going to be primarily AVL, but to a lesser degree, lead 1. And if you look, you see, whoa, we've got serious reciprocal changes, significant ST depression in AVL, and then to a lesser degree, lead 1. So we have reciprocal ST depression in those leads. I then scan through my precordium, and what do I notice? That it seems like we've got some ST elevation in my lateral leads, just a little bit in the lateral leads. So we have a little bit of ST elevation in my lateral leads. And I've also got this big ST segment depression in V2. So what does ST segment depression in V2 mean in this case, right? So we know that the predominant region of infarct is the inferior myocardium, right? Down here, right, it's mostly in lead 3 in AVF and then also in lead 2. So we've got a significant inferior MI. And we know that inferior is often, a right coronary artery syndrome. And so the right coronary artery, 80% of the time supplies the posterior descending artery, which supplies the posterior myocardium. And so what's interesting is we don't have a lead that measures the posterior myocardium, right? The posterior myocardium is like back here, right? We don't have a lead that's measuring that, but we have a lead that's measuring the opposite of that. So in this setting, significant ST depression in V2 is essentially saying there's ST segment elevation on the backside of things. And so V2, that significant depression in this setting, tells me that there is posterior extension of this inferior MI. And that really hits at, this is probably a right coronary artery disease, right? You've got really to a lesser degree some lateral involvement, but there is still a little bit of lateral involvement, right? And remember, V5, V6 are more of the low lateral, right? 1 and AVL are high lateral, V5 and V6 are kind of the low lateral, right? They're in the armpit. And so this is all pointing towards this right coronary artery that's a dominant RCA that supplies the posterior descending, and so we get a little bit of that kind of inferolateral. And so what do we get here? What is this? We would call this like an infero-posterolateral, right? We've got all the things. And so we put this all together, and what do we have? We've got a sinus rhythm with a first degree AV block at a rate of 90 beats per minute with an infero-posterolateral myocardial infarction. And so this person has an acute occlusion of the right coronary artery. So, and don't forget that the right coronary also supplies the SA and AV node. And so maybe that's why we have a little bit of a first degree AV block, because the right coronary is not doing the best at giving our AV node blood, and so the AV node is slowing down, right? Cool correlations. So I hope this helps. This is a fun ECG. It's a little bit right in your face, but I think it's just the anatomy is very neat. And I hope this helps. And if you have questions about it, feel free to ask. And if not, I just thank you all for watching these videos. And if you have any questions, put them in the comments. And if not, have a great rest of your day. Take care.